Bismillah ar-Rahman ar-Rahim. Clinical features in pulmonary thromboembolic disease. The acute pulmonary embolism typically presents in four main ways: pulmonary infarction and small volume hemoptysis, plus or minus pleuritic chest pain, and arterial blood gases may be normal, and electrocardiogram ECG changes are uncommon. Localizing signs may be present, such as pleural rub by auscultation, isolated dyspnea in 25%, definite as acute breathlessness in the absence of, of hemorrhage or circulatory collapse. The thrombus is more likely to be central with hypoxia on blood gases. The patient may have sudden onset and unexplained breathlessness in the presence of risk factors for venous thromboembolism. There, there may be there may also be angina from increased right heart work and inadequate auto delivery to its muscle. Collapse or poor reserve in 10% may be due to small pulmonary embolism, often in an elderly patient with limited cardiorespiratory reserve. These patients can rapidly decompensate with even a relatively small pulmonary embolism. The clinical findings may be nonspecific and reflect more the underlying disease process and thus fail to arouse suspicion of pulmonary embolism. Circulatory collapse in a relatively or circulatory collapse in a previously well patient, hypotension plus or minus loss of consciousness in 1%, usually due to extensive pulmonary artery occlusion from massive pulmonary embolism, causing marked hypoxia and hypocapnia due to hyperventilation, and acute right heart failure with chest pain due to right heart angina, raised jugular venous pressure, and fainting on sitting up. ECG may be normal, show sinus tachycardia or right heart strain. Echocardiogram shows pulmonary hypertension and right ventricular failure. These patients have the highest mortality, up to 30%. Clinical features in chronic thromboembolic disease typically presents with more insidious onset of breathlessness over the course of weeks to months due to increasing load of recurrent small volume clots. Dyspnea and tachypnea, respiratory rate more than 20, are the commonest presenting feature and are absent in only 10% of patients. We should remember to consider pulmonary embolism in the differential diagnosis of unexplained shortness of breath, SOB, collapse, new onset atrial fibrillation, signs consistent with acute right heart failure, and pleural effusion. Examination of a patient with pulmonary embolism. The examination may be normal. We can find tachycardia and tachypnea, which are common. We can find atrial fibrillation. There is reduced chest movement due to pain. On auscultation, we can hear pleural rub and classically loud second pulmonary sound and splitting of the second heart sound with a gallop rhythm due to acute right heart strain. We can find hypoxia with hypocapnia due to hyperventilation and an increased AA gradient, but PaO2 may be in the normal range in young, healthy individuals. Low grade fever may be present. Signs of DVT common in around 25%. Acute right heart failure, low cardiac output, and raised regular venous pressure with reduced blood pressure and perfusion pressure. Deterioration in cardiac output on setting up when filling pressure falls. Diagnosis of acute pulmonary embolism. The diagnosis of pulmonary embolism can be difficult and involves a clinical assessment of probability. This takes risk factors, clinical presentation, and the clinical signs into account. Investigations performed may add weight to the clinical decision rather than being standalone. Diagnostic tests, therefore, the estimation of the pretest clinical probability of DVT and PE is of vital importance in interpreting the results of tests performed. The clinical pretest probability scoring systems include Wells score of DVT and Wells score for pulmonary embolism. Investigations in pulmonary embolism include the following: ACG, non-specific changes are frequent. Most commonly, there is sinus tachycardia, atrial fibrillation, right bundle branch block, anterior T wave inversion, indicating RV strains are common. The S1 Q3 T3 pattern is uncommon. The chest radiograph, a good quality departmental chest X-ray is required. No specific features are characteristic MPE, but it may reveal another pathology. Small effusions are present in 40%, 80% are exudates, 20% are transudates. Focal infiltrates, segmental collapse, and raised hemidiaphragm can also occur. Arterial blood gases may be normal, especially in the young and healthy, but hypoxia and hypocapnia due to hyperventilation with increased AA gradient are more common. D dimer, serum D dimer. The D dimer has an important role in diagnosing and excluding pulmonary embolism and should be used with a pretest clinical probability assessment following careful clinical evaluation by an experienced clinician. D dimers are sensitive for DVT and thromboembolism, but not specific. Brain natriuretic peptide BNP levels in acute pulmonary embolism reflect severity of right ventricle strain and the hemodynamic compromise, providing additional prognostic information to that of echo. Elevated cardio Elevated cardiac troponin levels are associated with worse short-term prognosis in acute pulmonary embolism. Heart-type fatty acid binding protein, an early marker of myocardial injury, is reported to be superior to troponin or myoglobin measurements for risks stratification of PE on admission. There are currently no universally accepted criteria for the measurements of myocardial injury in acute PE. Computed tomographic pulmonary angiogram is the gold standard investigation and is recommended as the initial imaging technique in suspected non-massive PE. It has a sensitivity of more than 95% and may enable an alternative diagnosis to be made if pulmonary embolism is excluded. Advances in imaging mean that a 16 slice multi detector RAW scanner can image the entire chest with resolution approaching 1 millimeter, requiring a breath hold of below 10 seconds. Emboli can be detected in 6 order pulmonary vessels, which are small that their clinical relevance is uncertain. CT pulmonary angiogram should be performed with 1 hour in suspected massive PE and within 24 hours of suspected non-massive PE. The sensitivity and specificity of CTPA depends on the location of the emboli with lower sensitivity for clot confined to the segmental or subsegmental pulmonary vessels compared with more central clot. CT pulmonary angiogram needs specialist reporting. In those with a high clinical probability but negative CT pulmonary angiogram, the options are pulmonary embolism has been excluded, stop anticoagulants, or perform further imaging as leg ultrasound, conventional pulmonary angiogram, venous phase CT to include the legs. Other imaging techniques, as we said, leg ultrasound, conventional pulmonary angiogram, CT venography, echocardiogram, transthoracic ultrasound. The treatment of pulmonary thromboembolism will be discussed in the next video.